Hey guys. So, just in preparation for your upcoming care placements, what we need to get you guys to do is go through some of the basic life support skills that you might be required to support on during that placement. So, what we'll do is we'll go through some of the sort of fundamentals of things that you need to know around sort of basic life support and CPR. So the session's going to look like this. So very quickly, I'm going to go over some of the theory, and then what we'll do in the session is go through the practical elements that you guys are going to need. So we'll go through the acronym DRSABC, which we'll go through in a sec. And then on the day, just so you know, we're going to have 3 different stations. We're going to have station 1 that covers the airway, breathing, and sort of rescue breaths that you'll be required to potentially give. Station 2 will cover the circulation and the chest compressions. And then station 3 will go through how to use a defib or an AED. And we'll go through the choking process and how you manage choking. We'll talk through very quickly some of the risk factors for cardiac arrest. We'll talk through some medical conditions that can also lead to cardiac arrest, and then we'll go through the competency checklist that you guys will need to fill in on the practical day to make sure you guys have kind of gone through everything. So this is the process. This is the acronym you guys need to know. So doctors ABC. So we've got D for danger. So you're going to assess the area, see what's going on. Is it safe for you to approach? Is there anything that's potentially going to cause harm to that individual? And then you're going to approach that situation. Your first sort of contact with the individual is to look for a response. Then if there's no response, then what you're going to do is shout for help. You need somebody and some assistance to help you to manage this casualty. Then, once you've kind of got help on the way, you're going to relay what information you require. So what help do you need? So you're going to need an ambulance, you're going to need them to phone 999 and outline that it's a cardiac arrest. Then we're going to go into the actual assessment of the ABC, so the airway, the breathing, and the circulation. So we'll talk you through over the course of the next sort of 20 minutes how we go about doing that. Now, you may have heard of the chain of survival, so definitely that sort of early recognition and call for help is super important. What you ideally need is them to have access to a defibrillator, potentially sort of get that heart going again, and then you are in a position where you can provide rescue breaths and chest compressions. So that early CPR helps to buy you time. It's very rare that just doing CPR alone with the chest compressions and the rescue breaths will bring them back to life again. It's going to be that early defibrillation. So getting that defib as soon as you possibly can and getting that administered is really, really important. The likelihood is if they come round or not, then they're going to need to go to hospital. So who's going to take them there? It's going to be an ambulance. They're going to be able to continue on that CPR and defib work on the way. And then obviously they're going to need potential intervention to work out what the cause was. Is there any other things that the hospital needs to add? So you might have a sort of different situations that you come across a casualty that can range from potentially being on a sort of a sporting environment into a warehouse, into a kind of a car, sort of traffic accident, whatever it may look like. So they're all different situations, and what you need to do as an individual, if you're the person approaching it, is work out, is it safe to approach? So is there any dangers, any potential sort of risk factors that might well endanger yourself and might be endangering that individual? The worst thing that can happen is that you have one casualty, you approach the scene, and then something happens like an electric shock, or there's some sort of something falls on you, and then we've then got 2 casualties and no one can help. Very much that same scenario of put your own oxygen mask on first, make sure you're all right and it's safe to approach. That might be a situation where you need to think about how you can make it safe. So it might be that you need to remove anything that's potentially dangerous. Can you adapt it? Can you move the casualty? And then things like just making sure that you yourself are protected. So is there a barrier between yourself and the casualty for both people's safety? So that's usually going to be PPE. So it might be gloves, it might be a mask. Obviously, we've kind of had aprons and things in the past. But very important to make sure that that scene is safe for you as well as the casualty. Again, it might look very different depending on what sort of situation that you're sort of entering. So if there's a situation like There is in the top left-hand corner where you've maybe got a car accident, an RTA, someone's been knocked off a bike, whatever it may be. That situation might look a little bit different to how it looks potentially if it's in a warehouse. So if you look at the top right, how's that person ended up on the floor? Have they fallen? Have they had a cardiac arrest? Has something fallen on top of them? Have they been hit by something? You often are sort of trying to work out with a bit of a detective head what it is that's happened. You might also have sort of sudden cardiac arrest even in really fit and healthy individuals. So it's not always those patients who have lots of comorbidities or risk factors. You might have someone with an underlying heart condition, like an athlete, Fabrice Muamba, Marc-Vivien Foe, for example. Two recent sort of examples, Christian Eriksen, obviously more higher profile. You might also have a situation where there's water. So when we think about using things like defibrillators, in essence, what you're doing is applying an electric shock through that individual across the heart to try to reset that heart rhythm and then get it to kind of restore its normal natural rhythm again. So if you have a situation where there's an individual who is in water, you're going to have to remove them from that water before you apply anything like a defib. So let's go through the stages really. So we've talked about danger and then that response and that shout for help. And then obviously kind of definitely kind of issuing that you want a ambulance because you're suspecting that it's a cardiac arrest. There's maybe no signs of airway, breathing, circulation. What that does is it lifts them up the queue. So they'll have an algorithm at the other end of that phone where they're looking at whether or not someone is sort of low risk. They might have just kind of broken their arm. Everything's sort of in place. There's nothing kind of protruding out the skin. That's going to just sit compared to someone who's in cardiac arrest. It's much, much higher priority call. So what are you going to do? So once you've kind of established that there's no response, you've got help, you've advised them to go and get some help on what you need and advised them to come back again. What you're going to do is that ABC assessment. So it's going to be a look, a listen, and a feel. So what you're going to do is apply a head tilt, chin lift, and then try and open up that airway. So when you tilt the head back, what you're actually doing is bringing the tongue off the back of the throat. Now, in that situation, what you want to be checking for is, are there any signs of breathing? How are you going to do that? With that look, listen, and feel, where you might feel breath sounds, you might hear breath sounds, and then in terms of feeling, there might be some chest movement up and down. It might be from an airway perspective that you look around that mouth and you notice that there's something that's occluding the airway. That might be a reason they might have choked, there might be some fluid around there, that might be causing gurgling, snoring, whatever. But as long as there is some sort of sounds that are coming out of that individual related to breathing, then the likelihood is they're breathing. From a circulation check, what you need to be doing is looking at whether they have a carotid pulse. So that's this one, where you're just coming in just slightly from the side of my Adam's apple, and then basically feeling with two fingers, not your thumb, to see whether or not they have a carotid pulse. If they're not breathing and they don't have any circulation, then what you're going to do is you're going to start CPR. Now, if it's an adult, what we do is we go immediately onto the chest. So we go middle of the chest, and what we do is we compress about a third of the depth of that person's chest. Obviously, we're all different shapes and sizes. It used to be sort of 5 or 6 centimeters down, but it's about a third of the chest that you need to compress. Don't go too high onto the top of the sternum. Don't go too low at the base where that Ziffy process is. So it's center of the chest, and you're compressing straight down. You're going to need a defib. So if you haven't already and you've got help, you need to make sure that you are getting a defib on the way at that stage. The ratio is 30 chest compressions to 2 rescue breaths. And you just cycle that continuously until either on your own, if it's on your own, or you share that responsibility with somebody else. The 2 rescue breaths can come in different formats. So it can either be mouth to mouth, it can be with a protective barrier, it can also be with a pocket mask, or you can use this sort of bagging piece of kit that you see here. So we'll go through this in a bit more detail. So if we go back to R, you're going to approach the individual. You're going to just gently shake their shoulders and you're going to say, hello, can you hear me? really loud enough to make sure that it creates a bit of a reaction. If there is any response at all, they open their eyes, they respond to you, that's great, isn't it? You've got a response. You know that they're breathing, you know that they have a circulation. So therefore they have an airway if they speak to you. So if they have that and they're breathing and talking to you, that's fine. What we're going to do is just put them into the recovery position and go from there. However, if there is no response at all, then again, what you're going to do is call for help and get someone to make sure that they're on their way. Now, this might seem obvious, really, but generally what you're going to do is you're not going to do a little token half-assed attempt at just shouting help. You're going to shout help with some serious intent when that's going to try and alert somebody to come and help you. If they don't come, shout again and say, can I get some help in here immediately? If they're not coming, just keep on intermittently shouting for help. If they're not coming, what you need is an ambulance, really, to get some support. So what you often end up doing is using your own phone, phone 999, put it on loudspeaker and put it on the floor next to you so you can then do CPR. Hopefully someone comes and you advise them to go and get a defib and phone an ambulance. As we said before, what you're doing is just requesting exactly what you need. So we need an ambulance. You've got a patient who's in suspected cardiac arrest. They're not breathing. They've got no circulation. You either have or don't have a defibrillator to hand, and you've started CPR. Can we get an ambulance as soon as possible for this individual? Now, when you're on placement or you're working, it may look quite different depending on where you are. So if you're in a hospital setting or a care home, the likelihood is they're going to have a defib not a million miles away. There's often a buzzer, an emergency buzzer that you press, which gets everybody to come. So if you have your inductions, just make sure that you know where those buzzers are. So if you do come across somebody who has collapsed and maybe gone into cardiac arrest, you can hit the buzzer and get them to come. Now, obviously, it doesn't always happen in a hospital setting. You might be out and about. There might be no one around you. It might be a sort of a shopping centre that you're in. Quite often, these public sort of big centres that have a lot of people have a defibrillator in it, but you may not know exactly where it is. So you may need to be very specific with your guidance in terms of kind of what you require, where you might go and find it, go and ask for help from someone who's there, or it might happen in the absolute middle of nowhere where you don't have defibs. It's a little bit kind of alienated, but you can have to be really clear with what you require and get that ambulance to come as soon as possible. Obviously, if you're in a hospital setting and you've got a crash team, there's not a great deal of point in ringing an ambulance. So, as I say, what do you need? Be really clear. Call 999, instruct the patients in cardiac arrest, and then they're going to triage that on their priority algorithm. Now, the reason I've put an X across this individual here is you can see she's on the phone, so she's not administering CPR. There's no reason you can't put your phone on loudspeaker if it's just you and get those chest compressions going. There's no requirement absolutely to do the breaths, but getting on that chest and pumping that blood round, which is oxygenated, is going to be really, really helpful. You need a defib. If you know where the defibrillator is or the AED is, tell the person where it is and what it looks like, how to find it, and then instruct them to come back and bring that to you. Let them know that you need that ASAP and to make sure that they do come back. Okay, so from an airway perspective, what we're going to do is that chin tilt, head lift. So you're going to put fingers onto the kind of bony bit underneath the chin, and you're going to put the other hand across the forehead and tilt from there. So once they are there, as I say, that opens up the airway. You might well see something that's obstructing it. If you can easily remove it, then do so. The ideal is you don't just do kind of a blind sweep into that mouth at all with a finger and just see if there's anything in there, because if they chomp down on it, that might well be pretty painful and detrimental for yourself. So please don't put your hands in there. Now, there's also management of pediatrics and babies. So if you have a child who's sort of under 18, then what you're doing is you're still performing that chin tilt. But if you've got a baby, what you're doing is just taking them to neutral. So you can see the in the picture on the bottom, you can see the sort of medical professional there just lift into neutral. So they're not going into too much cervical extension because the airway sort of kinks, and then you're actually reducing airflow through that area. So just back to neutral for babies. To say, when we look at breathing, what we need to do is kind of have almost eyes onto the chest itself to see whether or not it is rising and falling. I really like kind of just putting a hand just across the upper chest, just to feel, because if they've got clothing on, it's not always super obvious, or if it's baggy clothing, you don't really know. You're going to listen to see whether or not there's breath sounds. That might be a case of getting your ear pretty close to their nose and mouth to see what's going on. There might be really shallow breathing. There might be a bit irregular. And then you'll get a good idea in terms of what's happening. The other thing that you might have is potentially sort of breath against your cheek or against your hand, if it's there. Again, if they're breathing, then just put them in the recovery position, which we'll go through in a second. If they're not breathing at the same time, what you should be doing is just checking to see if they've got a pulse. If there's a pulse there, then they're still alive. So this is where I would put it, kind of onto the picture on the right is better than the one on the left, I think, because you're going to see that sort of and feel that chest expansion at the top there. And as I say, what you will be required to show us on the day is that you can put somebody in the recovery position. So it's pretty straightforward. What you're doing is, number one, is taking their opposite hand and putting the back of their hand against their cheek, and you're going to hold it there. You're then going to lift up their leg, their far leg, up to kind of 90 degrees and stabilize it. And then what you're going to do is make sure you've got their other arm out at sort of an L shape into kind of horizontal abduction at 90, arm at 90-ish. And then what you're going to do is just roll them across. And then once they've come across, what you're going to do is just make sure that you open their airway again. So you're going to apply that sort of cervical extension, open the mouth, make sure that they're comfortable, realign their upper leg, and make sure that they're fine. Okay, so if you are required to do breathing, again, there's absolutely no absolute must for this, but we will need to see it from you. You can do it in different ways. So the first way is sort of direct mouth to mouth. So you're going to make sure you've sterilized the dummy beforehand with a Clini wipe. What you're going to do is ideally put them into that position, which opens up the airway as much as possible. Pinch the nose, create a seal, and then basically just breathe in. Now, what you need to do is not blow with all of your entire lung volume. It's a normal breath out. Move your head out the way and then come back in again to apply your second breath. Now, if you have one of these, or these are certainly something I'd recommend, is getting one of these little protective barriers. So it just creates a protective screen really between yourself and the patient. And what you're doing is, again, just doing the same sort of thing, breathing into that little blue tube. There's no contact between yourself and the patient. And a really useful thing, really portable. You can just put it in a little pack and go from there. Now, we do or will have the pocket masks as well. Now, these are also brilliant to have. I would definitely buy one of these if you haven't got one already. They're an excellent little tool for multiple different reasons. It's obviously a barrier between yourself and the patient. It's a one-way valve, so nothing can kind of come the other way. It improves the sort of ventilation efficiency that you have, as long as you've got a good seal around it. So basically what you need to do when you first open the pack is you'll find that it's actually indented. You need to open it up like it is on the right hand side, and then you'll be able to put that over the patient. The advantage of these guys is also that you have a little port that you can attach oxygen to, and yeah, that just means you're going to get a higher concentration of oxygen to the patient or athlete, or whoever it is, and go from there. Now, the pocket mask looks a little bit like this on the left-hand side. So when you open it up, it'll have this little attachment that you might need to just pop on. And then what you're going to do is it's almost a little bit like a triangle. So the pointy bit for adults is going to point up towards the forehead, and the sort of flatter base of it is going to go to the chin side. You'll see on the right-hand side, again, we've got that head tilt, chin lift position, which opens up the airway. When you have that, you'll more effectively get air into the lungs that then, when you do your chest compressions, disperses all of that around. There is also going to be the bag valve mask that we show you. So this is the pocket mask, but then you can attach onto it the bagging piece of kit. So this is really useful and just saves the person doing the breaths themselves, or a two-person technique that I'll show you in a second. But what it means is you can actually compress some of that bag rather than doing the actual breaths yourself. Now, just for reference, the bag is usually about 1,500 mils. The tidal volume of our lungs is about 500 to 600. So you're only looking at squeezing that bag about a third of the way. Don't come with two hands and squeeze the whole entire thing, because you'll overinflate it, potentially cause some vomiting and what other trauma into that area. There's different ways that you can get someone to hold the mask on if you've got a two-person technique. So if there's someone at the head end and you're doing the chest compressions, what you can do really nicely is get them to stabilize the pocket mask either with that C-shaped technique or the thumbs down. Any air that gets in through the sides, it has got a nice little sort of air inflated cuff around it, but if it's not flush against that individual, then there's going to be air that's escaping. The less air that's getting into that individual, the less oxygen they're going to have, the more likely it is they're going to fail that from there. Now, this is just how to attach the bag, and then this is what it looks like. So you can see it's about a third of the compression rather than that full attachment. So attachment goes on, and you can see rather than doing mouth to mouth, you've got this that's then applying the ventilation for that individual. So you can do this on your own, which is tricky. Ideally, you'll have two people doing it with you. So you've got one stabilizing the mask, the other one doing the chest compressions, plus or minus that bagging technique from there. Now, again, once we do it, you'll see here, you can either have the bag sort of down the middle of the chest, or quite often what you'll have it is over to the side. Again, make sure that it's covering the nose and the mouth. The bag volume is about a third of the lung tidal volume, so only squeeze about a third. So it's much better to do this, I find, just with one hand, and it stops you overinflating when you do it. Now, if you've got a pediatric situation, so a younger child or with a smaller face or even a baby, what you normally do is do it the other way around. So you kind of cover the whole face, pop the bag on as usual, but just bear in mind, obviously, their lung capacity is much smaller, again, depending on where they are. If they're 0 to 17, where are they on that level? What sort of size are they? But yeah, just bear in mind, the typical adult's about 500-600, so almost gauge how much you're going to inflate from there. Now, then you may also be asked on placement to get a trauma bag. Now, usually this is green, and it's just to let you know that this is kind of roughly what it looks like, and it'll have a number of different adjuncts that are in it. So things that you can help maintain the airway, like a nasopharyngeal or an oropharyngeal airway. It'll have the masks in. It's not common to have the gases in. Usually the oxygen's in a separate canister that you'll see on the sort of right hand side. But yeah, in there you'll often have like a non-rebreathe mask with the tubing, so you can attach it onto the oxygen. So it might just be a case, if you get asked to bring the trauma bag, it looks a little bit like this. And when you have the sort of non-rebreathe mask on with the tubing, what you will typically see is whoever administers it, they will do what's called priming the mask, where they kind of put their thumb on the bottom. It fills up that reservoir bag at the bottom, so then they're breathing in more higher oxygenated oxygen through the tubing, and obviously kind of the more oxygen you get in there, the less risk there is of complications and things later on. Now, they'll often be fogging the mask, it's called. So if they are fogging that mask, a bit like if you were breathing up against a window, that's a good sign that they're still breathing. If you come across oxygen, again, just as a bit of a heads up, you won't be required to do this in the session, but usually what they are sealed. So you'll see this canister, you'll see on the left-hand side, there's a little contraption that you just pull off and peel off. And next to that, you've got a bit of a gauge. Now, what you can do is turn up the amount of oxygen that you require. So usually it's about 15 litres of oxygen to kind of get a good old dose into them. The gauge will tell you how much oxygen is left in there. Ideally, you don't get a chamber that has next to no oxygen left in it. So it's always important just to check. But if someone asks you to kind of get the oxygen, at least you know a little bit about it. Now, the slight difference in terms of rescue breaths with a pediatric casualty is that the majority of the time it's a respiratory cause to why things have happened rather than a cardiac. It's rare that babies and kids have underlying heart conditions that would cause the cardiac arrest. It's much more likely to be a respiratory related issue. With a pediatric patient, what you need to do is, rather than going straight to the 30 to 2, so the 30 chest compressions to the 2 rescue breaths, what you start with is 5 initial rescue breaths, and then you go to the 30 to 2. It just means you're going to get more oxygen into that individual compared to adults, where you just literally, you find that they're not breathing, they have no circulation, and you go straight onto the chest and do 30 chest compressions to 2, and you just keep cycling that continuously. If you aren't familiar, have a go at practicing finding someone else's carotid pulse. You'll see the position of it in the top right hand corner, so kind of almost just straight off kind of Adam's apple over to the lateral aspect, about an inch-ish, and then basically just use your fingers. Make sure you don't use your thumbs because they've got their own pulse, and you can work out kind of if there is a pulse or not. If they've got a pulse, you don't start CPR until they don't have a pulse. All right. If they are breathing though, then what you could do is potentially look at getting a resting sort of breath rate. So the way you do that is often just count for those 10 seconds, how many breaths. If it's 3 breaths in 10 seconds, that's going to be 18 breaths in a minute. It's quite handy sometimes for the ambulance just to know whether the respiratory rate is going up or whether or not it's kind of coming down a bit. This is just how it will look if you're applying your chest compression. So you'll see center of the chest, interlinking the hands. You're on your knees, you're kind of leaning over, your elbows are locked out. And basically you're going a third of the depth of the chest, or 5 to 6 centimeters for an adult. If it's a child, you typically do it with one hand because they're not going to need as much pressure. And if it's babies, you're looking at sort of 2 fingers to the center of the chest. This is just the baby one. So again, on the left-hand side, you can see sort of center of the chest, looking at depressing it about a third. Again, just obviously bearing in mind, you're not going to need anywhere near as much pressure because your risk of kind of breaking ribs and things or causing significant trauma is a lot higher with babies. There's been very few cases of adults successfully sort of suing anyone for breaking ribs in adults. The general reason why is because they'd be dead if they hadn't done the CPR for them. So don't be afraid about getting onto the chest and making sure you're compressing it. Quite often there may well be rib fractures, costochondral issues, things like that come on the back of it. But the reality is you need to try and get that, you're mimicking that heart pumping to get that oxygen around the body. A common question is sort of when to stop. And in essence, if someone starts to show signs of life, hopefully you know yourself that you're not going to carry on. That's going to be the end of your requirement to do CPR, unless it deteriorates again and they lose signs of life. If help arrives and takes over, obviously they need to. If you physically can't carry on any longer, if it becomes unsafe to continue, so it might be the situation or the environment changes a bit, and ideally the ambulance crew will come in, they'll take over, they'll get the patient into the ambulance and take them off to hospital. Now you'll also be required to go through demonstrating the use of a defibrillator. So this is sometimes also called an AED. It's going to look like the top left-hand corner to start with. So you're going to find it in a little pack usually, and inside there what you're going to find is that there's some pads, there's the unit, and there might well be some scissors, there might well be a shaver to try and kind of make sure that the pads stick. If someone is really hairy, you might have to shave the area beforehand. But what this is going to do, you're going to put the pads on so they create an electrical shock basically through the heart. So if the heart is in a shockable rhythm, what will happen is the defibrillator will work that out and it will advise you exactly what to do. These are really straightforward, really simple. Once you turn them on, the instructions are pretty clear and you just follow the instructions. They'll tell you on the pads where exactly to put them. So one will be sitting in that sort of top right-hand corner, one on the left flank. And basically just imagine a line going straight between the two pads that has to go through the heart. So that's going to help you eyeball that you're in the right kind of area. You're going to apply the defibs around whoever's doing that CPR. We can't stop doing CPR while the defib pads are going on. The reason for that is if you interrupt those chest compressions or that breathing, then potentially what we're doing is we're just not allowing that oxygen to get pumped around the body. So keep going and work around that individual. Here's a little guide as to how to do it. Hopefully it works. Might have a bit of a introduction to start with.
Glenn's just used Confused.com and doesn't have the thought of home insurance weighing him down anymore.
Can't believe we're getting married.
You're not getting married. Insurance feels better when you've just used Confused.
Hi, my name is James, and today we're going to be talking about the use of an automated external defibrillator, or an AED. They are a key part of delivering both basic and advanced life support. When you have your defibrillator, inside there will be the defibrillator itself and some pads in a foil packet. When you open the foil packet, there'll be a lead for two pads which will demonstrate where they should be placed on the chest. Firstly, turn the defibrillator on.
Apply pads to patient's bare chest.
Then place the pads in these positions, here and here.
Plug in pads connector next to flashing light.
Then connect the pads to the defibrillator.
Analyzing heart rhythm. Do not touch the patient.
Then you need to follow the instructions of the defibrillator as it analyzes the rhythm and will tell you whether a shock is advised or not.
Shock advised. Charging.
If a shock is advised, wait until the defibrillator has finished charging.
Stay clear of patient. Deliver shock now.
And then press the flashing button.
Shock delivered. If needed, begin CPR.
After you've delivered the shock, you'll need to continue CPR. Then the defibrillator will time for 2 minutes, at which point it will ask you to stop doing CPR and it will reassess the rhythm.
Okie doke, so hopefully that gives you a bit of a visual in terms of what it will look like. The big key thing that we need you guys to do is make sure that you don't shock anyone else at the same time. So it's really important that when you administer the shock, that you're really clearly saying, do not touch the patient, stay clear, I'm going to administer the shock. Basically, if you electrocute them and someone's touching the patient, they will also become electrocuted and you might end up with more casualties. So really clear, everyone stand clear, I'm administering the shock, have a little look around, make sure no one's touching the patient, and then you can administer that shock. The slight difference for pediatrics is they actually, because they've got a much smaller chest, then what we do is we go front and back. So we put one on the anterior aspect, one on the posterior aspect, right over where that heart would be in the middle of the chest. And it's the same principle. You're just going to use a pediatric defib for that. On the left-hand side, you might well have seen these in the real world. You often have defibrillators locked away in little cupboards that are going to require whoever it is who's going to try and unlock it to basically either ring a number and get a code so they can access that defib. The reason it's locked away is because obviously you don't want that to disappear if someone needs it. They're really expensive, but it does delay getting that information through. So it's really useful to kind of roughly work out where the defibs are in advance if you're working in a place of work, and go from there. Now, that's pretty much the almost sort of CPR side of things. What you'll also be required to do is kind of go through a choking protocol. So what would you do if someone is choking? Now, what are they going to look like? Well, typically they're not going to say anything because they've got something blocking their airway, so they're going to try and grab your attention in some other fashion. So it might be that they're waving their arms around, they're pointing, holding their throat. They'll be looking pretty panicked and anxious. And what might well have happened is that whatever it is that's occluded their airway has occluded it long enough that they haven't actually been able to get oxygen into their system, and then they've collapsed as a result. So that might well be the case. So what are we going to do about it if they're conscious? Well, we're going to encourage them to cough, go through 5 back slaps, 5 abdominal thrusts, and we just keep doing that until it comes out. Obviously, if you do 2 back slaps and it comes out, what we're not going to do is just carry on whacking them on the back for another 3, because whatever is obstructed has already come out. So again, really important, encourage them to cough. Then, if that's not working, bend them forward, 5 back blows, 5 abdominal thrusts, and just keep cycling that pattern to make sure you get it. Encouraging the cough is just a verbal instruction. Try to cough if you possibly can to get it out. Pretty simple. When it comes to the back blows, though, this is kind of where you want them. So arm across the front, holding on to the other side. If you can slightly lean the patient forward, that's even better. And it's probably better if you're higher than the patient to do this, because if you're reaching up, you're not going to get as much force. So it might be that you just get them to sit down. I think that's a nice position. They can then lean on a table. They're pretty safe in that position. You're not required to hold them up. So that's a nice position. Now your blows, you're going to use the heel of your hand, and you're just going to go straight in between the scapula. And again, it's going to be up to 5 back blows. If it comes out, don't keep whacking them. If you aren't successful with that, then what we have is these abdominal thrusts. So basically what you're going to do is going to stand behind and slightly to the side of that individual. You make a fist with your thumb almost sort of into the patient. And then what you're going to do is create a bit of a J shape. So you're going to kind of come inward into their abdomen, and then you're going to come up that way. So you're kind of creating kind of a little bit of a J shape from there. And again, up to 5 attempts. If it's a baby, then what you can actually do is hold them on your forearm, and then obviously kind of administer your back slaps there. You've then got the advantage of gravity to help with that from there. That'll look a little bit like this. So again, sort of baby on the front, you're supporting the head, slightly tilted down, and again, 5 back slaps if you possibly can to try and get that out. Keep checking to make sure for sort of normal breathing again, just so you're not administering excess trauma. Now, sometimes there's a bit of a question mark around why some of the sort of sudden cardiac arrests happen. So these are some of the reasons why. So there might be some coronary artery disease, some heart valve disorders, high blood pressure, alcohol abuse, electrolyte imbalances in the blood. There may be some trauma to the heart. So they might have been struck in the chest by something. It might be electrocution, cardiomyopathy, changes in the heart muscle. Drugs and medication can obviously kind of lead to cardiac failure. Any genetic disorders that have been passed on, and any sort of defects that they might have. So people may well have had no issues in their whole lives, but as they've kind of gone to do something, it's obviously come to the surface. Now, there's just a few other things that can lead or make you aware of. Obviously, there's medical conditions that can eventually lead to kind of cardiac arrest. So asthma is one. If someone has a severe asthmatic attack, they're going to start to get wheezy, breathless. What are you going to do in this situation? Well, ideally, you'll be aware, or they'll be aware, that they need their inhaler. They should indicate that. Can you get it? And usually with a few puffs, things start to normalize. Ring an ambulance, get them off to hospital. It basically kind of boils down to that sort of bronchospasm that's happening, which can be reversible with the use of inhalers or nebulizers. And obviously there's lots of things that can kind of cause that to be triggered. It's also worth just being mindful of diabetes, so thinking about the blood sugar levels. If someone is diabetic and their blood sugar levels either get too high or too low, that can actually lead to issues and collapse. And it might be that you find that they've got a little blood sugar level checking device. If you have one, you might well come across something like this on placement. Quite a few people who are diabetic now have this little patch that you sort of see in the middle at the top, where it's a bit of an implant where, again, with the beauty of technology, you can hover your phone over there and get a good idea in terms of where they're at. You might also, the last one then, just to wrap things up, is you might have someone who has an anaphylactic shock. So there might be lots of different reasons for this. Allergies to nuts, people with allergies to orange. It might be that they've come into contact with something that's created a reaction. Latex is a common one. If you've had latex gloves on sometimes, that might have irritated someone's skin. But yeah, lots of reasons why people might go into anaphylaxis. You'll see some of the images of what can potentially happen where you get massive amounts of swelling and reaction into that area. It can be really dangerous for that individual because you get that sort of dilation all to your kind of peripheries. All your capillaries become quite leaky and things. So the management that you need to kind of be aware of are these EpiPens. So you may well have come across these before. This is adrenaline that you're basically administering, usually into that lateral thigh. If someone has a severe allergy or they're aware of something beforehand, they may well be carrying an EpiPen themselves. So it's worth asking, have you got your own EpiPen? Again, what you're going to do in all of these situations is phone an ambulance and get them to hospital to make sure that they're monitored, treated, and managed appropriately. Now, the last thing that's really important for you guys is you guys need to get signed off for all of these different areas. So there is a checklist. You guys are responsible for getting those ticked off by us and having yourself observed at each of these 3 stations. Hopefully by the end of the session, you will have ticked off all of these. Please put your name on, the date on, and then what we'll do is we'll check to make sure you've completed all those relevant sections, sign it off, an initial next to each area. And then if you are competent, which hopefully you are, we will tick all components completed. If you're not yet competent in certain areas, we'll get you to come back and redo that, probably at the end of the day. We'll give you feedback if that's the case, but keep a hold of this as proof that you've kind of gone through it. Now, if you've got any questions sort of on the back of this, feel free to ask them on the day or get in touch beforehand. But I hope hopefully that's a good little intro for you, so you get a bit more out of the session, make it much more practical, so we can fly straight into the practicalities rather than go through the theory. All right, folks, see you guys in the BLS session.